Our topic of discussion today is post-mortem examination. See, what are the step of post-mortem examination? First step is identification. See, let's say if there is a bomb blast injury or any fire injuries, then the bodies are mutilated. So we need to identify what person that is. Right. The first step is identification is done by police officer or the investigation officer. Second is if any external injury marks are present. Let's say the person is uh, had done the suicidal hanging, then there will be ligation or strangulation mark. So we need to document these injuries. So the police officer will identify and document these injuries. Now these injuries, whenever there is any abrasion or bruise, right, these injuries will tell you the time since death. So the abrasion and bruise will change its color and we can know the time since death. So we need to identify injuries and determine the time since death if it's possible. Third one is internal examination. Now this is due to if the death is due to hanging or any bullet injuries, but if the death is due to poisoning, then we cannot see any external findings. Now we'll have to do what? Internal examination. And which cavity to open first, abdominal or thoracic, is the choice of autopsy surgeon. Most common is thorax, but now see, first the cavity to open is a choice of autopsy surgeon, but in certain conditions there are certain rules that we have to follow. Let's see which are those rules. See, in the what are the rules of dissection? See, whenever there is a case of poisoning, the first cavity to dissect is cranial. Why? See, let's take an example. This is example 1 and this is example 2. The person 1 has died due to any other reason, let's say myocardial infarction, and the person 2 is death due to poisoning, let's say cyanide poisoning. Now whenever a person is dead, in both the cases there will be decomposition, right? So the bacteria will decompose the body and there will be decomposition gases in the abdomen, right? So the abdomen will have decomposition gases in every death. Now the poison is also having its characteristic smell. So now let's say a person is died due to cyanide poison, then there will be, let's say, cyanide over here in the body deposited. Now the cyanide is having smell. Now if you open this abdominal cavity, then the smell of this decomposition caused by bacteria will mask this cyanide smell, so will not smell the cyanide properly. So that's why you don't open the abdominal cavity first, you open the cranial cavity first. So that's why there is no decomposition gases coming up, right? So in poisoning, first cavity to be opened is cranial cavity to detect the smell of the poison. Example, cyanide has a bitter almond smell. In head injury, obviously we are opening the cranial because the injury is over there only. Now what is Prinsloo Gordon artifact? See, let's start from very basic. What is a bruise? In this image you can see this is a bruise. How it is formed? Let's say we are applying a pressure on this neck, which is throttling. So when this throttling pressure is applied, let's say this is a cross section of the neck. When the pressure is applied over here, there will be rupture of this vessel. There is no injury over here, but these vessels will rupture, and when the vessels will rupture, there will be, let's say, extravasation of blood over here, and this will appear like this. This is a bruise. Why a bruise is formed? Because these vessels are broken down and there is extravasation of blood. Now let's say another case. In this case, the person is not any the person is not undergone strangulation or anything, but now you are incising the neck or you are cutting the neck to study it. Whenever you incise or cut the neck, you will cut the vessels also, right? So when the vessels will be cut, there will be again extravasation of blood or bleeding over here. So let's compare both of these. See, in here also there is blood and here also there is blood, so both these hemorrhage are looking same only, right? So if the person did not die due to throttling, if we open the neck, then it will appear as if there are hemorrhages, and these are caused by what? Throttling. So what we do, we need to make sure that whenever we cut these vessels, there should not be any blood inside it, right? That will study in next slide. But what is Prinsloo Gordon artifact? Prinsloo Gordon artifact means extravasation of blood in the neck at dissection. Whenever we are dissecting the neck, this extravasated blood is looking like an asphyxial death. Throttling is an asphyxial death, so we avoid the opening the neck first. Now how exactly we prevent this? See, We prevent it like this: we open the cranial cavity first. So when we open the cranial cavity first, the blood vessels will be cut over there and the blood will go outside over here. Then we open thorax and abdomen, so the entire blood is going away. Now when we open the neck, there will be no blood inside the blood vessels. If there will be no blood, then nothing will come out, so there will not be any hemorrhage, right? So we have prevented the Prinsloo Gordon artifact by doing what? Bloodless dissection. So in asphyxial death also, first cavity to be open is cranial, then thorax, then abdomen. Every blood is gone away. Now we open the neck. And now when we open the neck, if we find the blood or hemorrhages over there, then we are 100% sure that the person is dead due to strangulation, because when we cut that vessel, there was no blood inside it. If the blood is there, then it has to be present from before, right? So this was about asphyxial death. Now, in newborn, see, whenever a newborn is dead, we need to identify two things. First is it if the newborn was live after the birth, newborn was live and then newborn became dead, or he was born dead, right? So how will we identify? See, whenever a newborn is born dead, the newborn has never taken any breath, right? So the lungs are small and not expanded. So the diaphragm is at the level of third or fourth rib because lungs are never expanded. If the newborn was born live, then he would have taken the breath and the lungs would have expanded, will push the diaphragm down. So diaphragm will go down to sixth and seventh rib. So will in a dead newborn will open the abdominal cavity to look at the level of diaphragm. If diaphragm is above at third or fourth rib, third or fourth rib, then it is a dead newborn, or it is below at sixth, seventh rib, it is a live newborn. Now, these two conditions was first we'll learn the basic what are these two conditions. First is pneumothorax and second is air embolism. See what is pneumothorax? See, this is a normal lung. Okay, this is a normal lung where the space between this pleural layer and the lung layer is very little and there is vacuum over there. But whenever there is any injury, trauma or anything, the space fills between lung and the outer layer. So here there is air in this layer. Due to this, the lungs have collapsed, and this will be the reason of death, right? So in pneumothorax, we can see this air in between two layers. In the same way, in air embolism, what happens? Let's say these are the layers of the skin, then there is a blood vessel. Now, due to any iatrogenic or accidental mean, this procedure inserts some air inside this blood vessel, and this air bubble, whenever there is an air bubble in that blood vessel, it is called air embolism. So normally the heart vessel or anything does not have air, but if there is an air, it is called air embolism, and there can be death due to it. So there is death if there is death due to pneumothorax, or there is death due to air embolism, then which cavity we will open? Let's see. So in pneumothorax, what we do is we know that there is air over here. What we have to identify? We have to identify this air presence, right? So we'll open the skin flap, then we'll open the sternum, and then we'll pour water in this pocket. So whenever the water is present in this pocket, then we will what? Then we will incise over here, incise the intercostal space. When you will incise the intercostal space, this air will make bubbles inside those water, right? So we'll open the skin flap, pour water in that pocket around, and then incise the intercostal space. Now this air which is over here will make bubbles in this water. So we'll have detected the presence of air, and the presence of air detects what? Pneumothorax. In the air embolism also the same way. Here it we are not doing in the lungs, we are doing it in the heart. So we'll fill pericardial cavity with water, then we'll puncture the ventricle. If there are bubbles, then the presence of air is confirmed, right? Now there is a specific test for air embolism, which is pyrogalol test. What is a pyrogalol test? In this we use a syringe, and in this syringe we put two things: 3% pyrogalol and NaOH. So we have put this 3% pyrogalol and NaOH inside the syringe, and then we will aspirate the content. Now aspirate the ventricle. Now if there was air inside the ventricle, then that air is going inside the syringe. Inside the syringe, what is there? There is pyrogalol and NaOH. Now this air will react with pyrogalol and NaOH, and there will be a brown color. So the brown color will brown color will detect what? It is detecting the oxygen. See, whenever a person is dead, there is putrefaction, right? So the bacteria decompose the body, but they don't produce any oxygen. If there is an oxygen, then it is due to what? Air embolism, not due to bacterial activity. So this pyrogalol test detects brown color, which is oxygen. And what are the reagent? It is 3% pyrogalol plus NaOH in the syringe. Now, type of skin incision. See, first is primary, which is applied on the, let's say we are dissecting the thoracic cavity. Then we'll apply the first skin incision. Then we'll apply the incision on sternum or rib, which are the bones. Then the lung membranes or heart membranes. Then individually the organs like lungs and heart. So there are four type of incision: primary, secondary, tertiary, and quaternary. Now we'll study about each in detail. See, first of all, primary incision or the skin incision. Now there are three main skin incision. First is I-shaped incision, second is Y-shaped, and third is modified Y-shaped. I, Y, and modified Y. See, in I-shaped incision, the incision is starting from chin up to pubic symphysis. But see, this umbilicus is not cut. Why? Because umbilicus has a thick tissue over there. So if we cut this umbilicus, it will be very tough for us to suture it back. And why do we want to suture it back? Because we have to give this body to the relatives or anyone for their procedures, right? So we don't cut the umbilicus over here, so avoid the umbilicus. Incision is made from chin up to the pubic symphysis. And why are we making this incision? To study the organs, whether there is poisoning or anything, to studying the cavities. Second is Y-shaped incision. Y-shaped incision, let's first look at the location. It is applied over here below the breast, and it starting from the acromion process. So from acromion process to the below the breast, then it is same up to the pubic symphysis, and we avoid the umbilicus. So now this eye incision is the standard incision. We most common incision is eye incision. Why? Because a single incision opens all three cavity: thoracic, abdominal cavity, right? So we need only one incision to open thoracic and abdominal cavity. Then why there is a need of Y incision? Because for cosmetic purposes, because the body has to be given back to the relatives, right? So we cannot make this incision over here like this. For cosmetic purposes, it is done below breast over here, right? So this was Y incision. Now modified Y incision, as I told you in the previous example, there was throttling case. So whenever there was throttling case, there was some blood inside the neck, right? So if you want to see or examine the neck cavity, this cavity in asphyxial death, we need this modified Y, where the incision is done from mastoid process over here to the suprasternal notch. So from mastoid to suprasternal notch, and the bottom is all the same, right? So eye incision is the most common. Y incision is done for cosmetic purposes, and this modified Y done for asphyxial death. Same I explained. See, eye is most common and easy, and single neck incision that opens all three cavities: neck, thorax, and abdomen. Second is Y incision. We are doing it below the breast for cosmetic purposes, and modified Y is done for asphyxial death, where we have to examine these bruises in the throttling or the neck injuries. Now there is an inverted Y. See, why do we need an inverted Y? In the child, we are doing this incision where the incision is going from chin up to umbilicus and then bifurcating. Why do we need to bifurcate the incision? Because we know at the umbilicus there will be umbilical vein, right? Now this umbilical vein has some evidence in case of child death or anything. So we don't want to cut this umbilical vein over here. So we bifurcate from there. Let's say this is umbilical vein, then we apply the incision over here, then we bifurcate it. We don't cut that incision, right? So it is used in newborns, inverted Y incision. Now, yes, now the less important one, T-shaped incision. See, this T-shaped incision is called bucket handle. It starts from acromion and then below the clavicle, so below subclavicular line, and from here vertically same up to the pubic symphysis. It also does not involve the umbilicus. Uses are not important. This is just a less common incision, T-shaped incision. Second is X. It is done on the posterior side of the body. So in custodial death, there is a torture. So there is a beating behind the back of the prisoners, right? So in this we do a posterior surface X incision to assess the deeper injuries or bruise or internal injuries. Now organ removal technique, we have made the skin incision, right? Now we need to remove those organ to examine those organs. See, first technique is Virchow's technique. In Virchow's technique, what we do, we study this organ one by one. So we'll remove the sorry, lungs first, and then liver first, then spleen first, like that way we are removing one by one each organ and we are studying it. Now what is a disadvantage is we cannot study the inter organ relationship. Let's say the cancer started from lung and it is spreading all over. So if when we are removing individual organ, we cannot see that spread or inter organ relationship. So it is the most common method and we can study each organ in detail, but we cannot study inter organ relationship. So this was a disadvantage, so we discovered another method. This is lettuce or n mass. In this method we are removing entire organ as a single mass. From starting from tongue to anus, every organ is removed as a single mass. Now this will have advantage that we'll study inter-organ relationship, but this big amount of mass is difficult to handle. So the disadvantage is it is difficult to handle. Advantage is we can study the inter-organ relationships, and we can, the process is rapid because we are not individually taking out one organ, we are studying the entire block. It can deter fetal malformations also. Now, Ghon's technique or blocks technique. See, this is a mixture of these two. Here, what we do, we don't remove each and every organ, nor we remove the entire thing. We divide it in parts like cavities. We remove the thoracic cavity first, then abdominal, then urogenital, like this. So it is easier than en masse. Last one is, let's say we are, when in what condition we are afraid to remove any organ. Let's say the person died due to HIV exposure, right? So if we examine it in thorough detailedly, there are chances of getting the infection due to the trauma, and also we don't remove any organ. Here we examine just in situ. We take some samples and whatever we can examine, we do that. So this is Rokitansky method or in situ method, which is used in HIV exposures. So let's just revise the name of the techniques. First one was Virchow's technique. Each organ was removed. Second was lettuce or en masse, a block. Every organ is removed from tongue to anus. Third one is mixture of these two, Ghon's or block technique, where specific blocks are removed. And last one is in situ or Rokitansky. So in situ is Rokitansky, Ghon's is block, lettuce is en masse, and Virchow. Now head dissection. See, first of all, the skin incision. Which are the skin incision? It is a bi-mastoid incision. Starting from this mastoid process to the opposite mastoid process, we have a mastoid bi-mastoid incision, and this scalp is reflected as anterior and posterior fold. This is the anterior fold and this is a posterior fold. Now why do we make this V-shaped incision? We cannot just make it a circular over here, right? Why? Because if we make it a V-shaped, then afterwards when the body is combined back and given to the relative, it is much easier to make this skull world stay in that space, right? If it's round, then it might fall off, right? But it's getting a grip, so we are making a V-shaped incision in here. And how is this scalp is cut with the help of this scalpel, but the skull is cut with the help of striker saw or electric saw. So we cut a V-shaped skull over here in the brain opening, right? Now the brain is removed. And how do we examine brain? See, most common method to examine brain is fresh. When the brain is removed, just examine it. But the brain is like gelatinous or jelly like. You cannot examine it as such because it will, you cannot be able, you won't be able to get those proper tissue from out it or the proper sample source. So what we do, we fix it inside the formalin. It will make the brain hard, so now you can properly cut it and get the sample of your size. So formalin fixed is ideal, but most common is fresh or just examine. Why? Because the formalin fixed takes 2 to 3 weeks. After 2 to 3 weeks you will examine that. Now the most common method to cut brain is in the coronal plane to examine the parenchymal lesions. See, these are different type of planes. This is a coronal plane, this is horizontal, and this is a sagittal plane. So in most common method is the coronal plane incision to see the brain parenchymal lesion. Now in fetus, see, the skull of fetus and adult is different. The fetus skull is soft first of all, and the sutures are also not fused in it. So we can't use the same technique in fetus skull. So fetus skull we have different techniques. First one is, see, butterfly shape, two butterfly shaped flaps. See, this is one and this is two. So we have two butterfly shaped shape but sorry, two butterfly shaped flaps in fitter, which is Benick's method, and in Barr's method we have four flaps. So four flaps in Barr's method and two flaps in the Benick's method. So this was opening the skull in the fetus. Now, see, spinal cord dissection is not usually done. It is done only in suspected cases. There are two methods. First is anterior and posterior approach. If you go anteriorly, see, spinal cord is at the back. Now, if you take anterior approach, then you have to dissect the thorax, abdomen, everything, and then you will reach at the spinal cord. But in the posterior approach, it is more easier. We don't need any anterior dissection. The spinal cord is right here. Now, what are the advantages of posterior approach? See, here over here you can see this brain is continuous with the spinal cord, right? So we can see this continuity in the posterior approach. In the anterior approach there is obstruction over here, so we cannot see it. So first advantage is it is easier, obviously, because we are not cutting abdomen, thorax, exit and everything. We are just approaching the bed, so it's easier. Second is better spinal cord, cervical spinal cord access. This cervical spinal cord is better accessed and we can see the continuity very well. Now in the anterior approach, advantage is whenever you anyways have to open thorax and abdominal cavity in some dissection. So when you do that, it is advantage that you can also examine the nerve roots and dorsal ganglion if you have reached deep over there, right? So there is not anything more advantageous in anterior approach. It's just a bit that if you have opened thorax and abdomen, then you will reach at the spinal cord, so you are examining nerve roots and dorsal ganglion also. Disadvantage is it's complex because you have to do a lot of dissection over there. Now, hard dissection method. See, let's say there is any obstruction over here, and due to this obstruction the patient has died. Now when the patient is died, we need to examine every cavity, like we are examining this heart, and we need to know the site of obstruction. So what we do, we don't just randomly cut the heart to find that clot. We go in a proper sequential direction, right? We go from first right atrium to the right atrium valve, then right ventricle, and then over here we reach. So we are going in this blood flow direction to systemically reach at that clot, right? So the most common method of heart dissection is inflow outflow method. So we start cutting from here, and then when we reach here we see the clot. So we make a diagnosis that okay, the patient is dead due to clot over here. So along the direction of blood we have inflow outflow method. Now this is not the only reason why a person is dead due to a heart pathology. There are different reasons. See, one of it is cardiomyopathy. What is cardiomyopathy? This is the normal ventricle muscle, but when the ventricle muscle is enlarged, it cannot pump the blood properly. So the person is dead due to this reason. So this is enlarged myocardium. Second is myocardial infarction. In this, the artery that is supplying the heart has some clot over here. So the blood is not flowing properly, so the heart muscles are not getting blood. Now if the heart muscle won't get blood, the heart muscles will die eventually and there will be loss of contraction. So this is myocardial infarction. Now in both this condition, what is happening is the walls they are damaged. In here the walls are enlarged, and in here the walls of the heart are dead. Now if we want to examine these walls of the heart, we need to cut the heart and look at the wall thickness, right? So for this reason we have another two techniques. This is ventricular slicing or short axis method. See, this is the axis of heart. Now we cut this perpendicularly to the axis of heart, like here we can see we are cutting it perpendicularly. So when we cut it perpendicularly, we can see the thickness of the heart muscle, right? If the heart muscle thickness is enlarged, then we can say okay, the patient has died due to the this reason, cardiomyopathy, the heart thickness where it has increased, right? Next method is sandwiching or intramural. In here what we do, first of all, this is an axis of heart, so we in this ventricular slicing or short axis method we applied the cuts perpendicular to this axis. Now we are applying it parallel to the axis. So sandwiching or intramural method, we are applying multiple cuts along the muscle plane parallel to the axis. So sandwiching is parallel and ventricular slicing is perpendicular, and this is used to detect the fibrotic plaques or infarct. See over here, this is an infarct, or the heart is not getting any blood, so it is having an infarct in the walls of the muscle. So now we need to apply a perpendicular cuts to see this infarct inside the wall of the heart. So we have two methods, ventricular slicing and sandwiching. Ventricular slicing is perpendicular, sandwiching is parallel. Okay. Now stomach dissection. See how when we need to dissect stomach, in what cases? Let's say there is a poisoning cases and there is the person has died due to ingestion of the poison, so there will be poison inside the stomach, right? So when we dissect the stomach, we are making sure that this poison doesn't leak out. So we'll apply two ligature cuts, here one cut and here cut. So we'll ligate this and this part and then we'll dissect. So there is double ligation, and then we are examining the gastric cutting. Now whenever we are applying the incision, what do you think? We should apply it the greater, sorry, at the lesser or the greater curvature? See, there's a term called Mengestre. What is a Mengestre? That when there is acid consumption, the acid goes along the lesser curvature. Now imagine, acid will not just fly off and go to this, right? It will obviously go to the lesser curvature because it's a shorter part due to gravity. So in acid consumption, area of maximum damage is lesser curvature. So now if we apply incision over here, then thus findings can be disturbed, right? So we apply it over the greater curvature. So incision site is greater curvature. Why? Because in acid consumption, maximum area of damage is lesser curvature. You don't want to destroy that evidence, right? So first is double ligation and then there is an incision. Now kidney, liver and spleen, the method is braid lofting or multiple parallel cuts in kidney, liver and spleen. Now the samples for DNA. See, if it's early body or there is no decomposition, then the best sample to use is blood for the DNA analysis. But if there is decomposition, then we take muscle or spleen, early decomposition, and then late decomposition, there only bone or teeth or hair roots that can be there. Now what is exhumation? See, exhumation is disinterment. What is interment? Interment means burying. Disinterment means removing the body which is already buried. Now do you think you can just go to any grave and remove entire every bodies over there? No, it is prohibited. Why? Because whenever the person dies, that is its final state of rest. Okay, you cannot disturb the person from there. So now if you want to remove that body or want to do an exhumation, you need authorization from the magistrate. Who is a magistrate? It's a smaller term for a judge. So magistrate has to be there, police and doctor, everyone has to be at that location. It is authorized by magistrate. You have to take it their authority under the section 196 for BNSS. Time limit is, there is no time limit. See, if there is any evidence that a person holds, then you need to remove that body for that evidence to provide justice to the state. Procedure time early morning, you can see you can see changes better in the daylight. Obviously we are not doing anything at midnight or evening when we can't see anything, right? So if you want to see the proof over here or any findings, we need to do it in early morning. Now what is post-mortem imbibition? See, whenever the body is buried for a long time, if there was any poison inside the soil, it would have been absorbed by the bones, right? So absorption of metallic poison from soil into the body after death, this is post-mortem imbibition. And which is the most common poison? It is arsenic. So how will, if we are imbibing the body and there is poison inside the bones, how will we say that the poison came from soil or it was killed due to that arsenic poisoning, right? So in actual poisoning, arsenic in the body will be much more than in soil. But if there is a post-mortem imbibition, then there will be more poison in the soil than in the body. So this way we will differentiate the post-mortem imbibition. So see, if you want to study arsenic in the body and arsenic in the soil, then we obviously need to take samples from the soil and body both, right? So we are taking a control sample from the soil. Sample is taken from the soil to rule out post-mortem imbibition. So we are taking a lot of samples whenever the exhumation is done. So the 6 samples are taken from body: anterior, posterior, superior, left, right, and each 500 gram or so. We take 6 samples from the body and one control sample from the surrounding to rule out the post-mortem imbibition.